Hi everyone, I'm Courtney Merwin and I'm a third-year medical student at West Virginia School of Osteopathic Medicine. I'm presenting our project evaluating quality assurance in mammographic screening and follow-up in a rural setting. When patients have breast imaging, radiology uses the Breast Imaging Recording and Data System, BI-RADS, as a reporting schema. The BI-RADS system was developed by the American College of Radiology. It has 7 categories that range from 0, meaning that the study is inconclusive and the patient needs additional imaging, whether that be additional views on mammogram or maybe an ultrasound, to 1, that is completely negative, there are no lesions, masses, calcifications, 2, that any findings that are there are known as benign, all the way up to 6, meaning that the patient has a confirmed biopsy-detected cancer. The National Comprehensive Cancer Network then uses the BI-RADS classification system to provide clinical recommendations and next steps for screening or further workup. Despite these explicit guidelines, we're noticing trends of patients that have BI-RADS 1 or 2, which remember are benign, who are ending up in the surgery clinic. And we hypothesized that there are inappropriate referral practices occurring within the Holzer health system. With that being said, the goal of our study was to verify the sensitivity and specificity of BI-RADS within the system in order to assess its validity and then to evaluate the referral practices of patients with benign lesions. A retrospective cohort study was performed of 3,121 patients that underwent bilateral screening and diagnostic mammography in 2022 at Holzer Medical Center in Gallipolis, Ohio. A query was posed to the electronic health record to obtain the data, and manual analysis was performed to categorize multivariable groups. These groups included individual person by medical record number, number of screening and diagnostic mammograms, BI-RADS category, ordering provider specialty, diagnosis, and follow-up by specialty. Patients were then excluded if they had a prior breast cancer diagnosis because of our aim to evaluate referral practices for benign lesions. In 2022, 379 diagnostic mammograms were completed. 50 of these were excluded from the study due to known breast cancer diagnoses. Of the remaining 329, 257 of these mammograms had BI-RADS classifications of 1 or 2. 72 of these patients received a general surgery referral. One limitation of our study, though, is that we did not quantify which patients were clinically symptomatic compared to those who were referred to surgery prior to having imaging results available. After confirming the validity of the BI-RADS classification system within our health system, we conclude that there is an inappropriate referral practice occurring for patients that have benign breast lesions to the general surgery clinic. Because all diagnostic mammograms are read by radiology same day in order to obtain additional views and make a BI-RADS classification, moving forward, our goal is to implement an order set in the electronic health record that prioritizes a next day follow-up in the primary care setting. This kind of follow-up will allow patients to obtain their results and then at that time get a timely referral to surgery if it's clinically indicated. Thank you for listening, and I hope you enjoyed my presentation.